Hello everybody, so my name is Thuan, and today we'll be talking to you about health literacy. And just like Kate said, please out there, although the slide is in front of you, we do have a camera on you, so if you do raise your hand to ask questions or to interrupt, that is perfectly welcomed. Okay. So hopefully by the end of this discussion, you'll be able to identify some signs and risk factors for people with low health literacy, and also walk away with some very clinically applicable tools to assess for health literacy as well, as potentially also some ideas that we can troubleshoot together in terms of how to mitigate the impacts of low health literacy. So we'll start off with a case, and so this is a case that I saw as a fellow about 8 years ago. And so this is HN. He's a 71-year-old gentleman who lives out in the community. He has all these comorbid conditions. He's a diabetic with high blood pressure, with dyslipidemia, depression, osteoarthritis, and he's seeing me for the very first time to establish care with me. Fortunately, he brown bags his medicines, meaning that he brings in all his medicines in one big bag. And so his medicines are listed there. He's on aspirin, metformin, and glipizide for his diabetes, hydrochlorothiazide, lisinopril for his high blood pressure, citalopram for his depression, and acetaminophen that he takes as needed for his osteoarthritis. His social history, he is independent with his ADLs and IADLs. He is married. He lives with his oldest son, and that's because his wife had a stroke, and so his son is providing care to his wife that the patient himself can't. The patient himself does not drink, there's no alcohol, and there's no drug abuse. Of note, we did receive some prior clinic notes from his prior provider showing that his A1C, a measure of how well his diabetic control was in the past 3 months, is 8.6. And his blood pressure is elevated at this clinic visit. And so the idea was that we were going to increase his lisinopril and his glipizide too to a twice-a-day dosing from his once-a-day dosing. And then we arranged for a follow-up in 2 weeks. So that was the plan of care for this clinical visit. And luckily, there's a patient handout, and being the good fellow that I was, I wanted to give him some information on hypertension and blood pressure. And so this is a very typical thing that many of us will do within our electronic medical records systems now, that you'll go in and you'll print up some patient information. But the tricky thing about this information is that much of it is written at a higher grade level than many of our patients are able to read at. And so, for example, I took that up-to-date information there and put it into a calculator. And there's many different scoring systems that you can use out there to grade the grade level needed to be able to understand the material. But what this shows is that on average, it requires at least a 7th grade level of education to read this patient information on high blood pressure. And this is incredibly important later on when we're talking about assessment tools later on, is that if you're dealing and caring for someone who is reading below that level, the patient information material that you're giving to them, they might not even be able to understand. And not only that, though, but I've seen the transition to EMR, where although we're electronic, it's amazing that we're printing up all these after-visit summaries, that we've become much more reliant on paper as a mechanism of communicating what we want to do with our patients. And so we're assuming that they're able to read and that we're giving a plan of care to these individuals and that they're able to read and actually understand what to do with that information. So at the follow-up appointment, he brown bags his medications again, but unfortunately this time he's bringing in 2 bottles of his glipizide. So one bottle that specifically says 5 milligrams once a day, and another bottle that says 5 milligrams twice a day. And he brings in 2 bottles of his lisinopril. So from that 10 milligrams once a day that we had, and we upped it to 20 milligrams, so he brings up these 2 bottles. And currently he's complaining that he's still a little bit dizzy, but his blood pressure is elevated. And I find out that he's actually been taking both types of medicines at both of those dosages. And what he tells me is, oh, I just forgot your information that you had told me at 2 weeks prior. And so the reason why I think that this is really interesting from a geriatric medicine standpoint is that many of the signs, not all, but many of the signs that patients exhibit with low health literacy are also those same signs that we might see in patients with impairments in cognition. And so, for example, patients who have incomplete or inaccurate forms when they're completing their new patient evaluations, or they're unable to give a very coherent past medical history of what happened to them, or they're missing appointments, for example, or they're missing the lab tests or procedures that you're asking them to do, and particularly with medicines, because as an internist, that's my procedure, is that I want to make sure that when I'm prescribing medicines that it's appropriate, but oftentimes with people with low health literacy and people with low cognition as well, is that a person might have the inability to name medicines or really state what their purpose or their dosing is. And I think that one of the red flags, at least for me, is that when a patient indicates the medicines by the color or their appearance and not so much by the labels or the indication, particularly nowadays that many of our medications are generic and they're made by different companies, and there's often changes in the formulary, and so depending on the color and appearance is not helpful at all. And there's some evidence as well that they're not taking the medicines, which is another sign. So as you're titrating or if you're increasing medicines and you're not getting the appropriate response, just have it in the back of your head. Is this impairment in cognition, or is it low health literacy that they're not understanding and that they're not carrying out the instructions as you anticipate that they should as well? I think that two other important signs is if in the clinical visit, if patients ask little or no questions at all, or if you're actually handing them the after visit summary and their eyes just really glaze over and they look completely confused. But so these are some of the signs that could suggest that a person has low health literacy, and also some signs that could suggest that they have early impairments in cognition as well. So here are some risk factors that are associated with low health literacy. And of course, age is up there. So being of older age is a risk factor. If they're a recent immigrant to the United States, where they do not speak English or may be illiterate also in their native language. If they're a minority ethnic group, that is also a risk factor as well. And interestingly enough, if you look at the literature, they were born in the US, but English is their second language, that they have limited, is what you would define as limited English proficiency. And that would also equate to low health literacy as well as a risk factor. And low income and not completing high school as being possible risk factors for low health literacy. As you can imagine, these things are so much tied into a patient's socioeconomic status as well. Okay? And why is this important is that it leads to poor health outcomes. So here's a list of everything that has been linked with low health literacy to poor health outcomes, where they're less likely to engage in preventative screening, that their chronic disease are poorly controlled, they're more likely to be hospitalized and re-hospitalized. There's an increase in health costs that's all associated with that. They're more likely to report poor health and poor health conditions, and they are also more likely to die earlier compared to someone who has higher levels of health literacy. So it's really interesting too is that many of us will use the mechanism of teach-back, but I'm using this study to illustrate that teach-back might not be enough. So what these authors did was they took this phrase, take 2 tablets twice a day, And they did a cross-sectional study looking at 3 primary care clinics in those cities that are shown on your slide there. And they took people who were in the waiting rooms of these primary care clinics, 18 and above, and they had to be English-speaking individuals. So these were all English speakers. And they asked them, do you understand take 2 tablets twice a day? So I asked you all out in the audience, what percentage of people identified as low health literacy actually understood take 2 tablets twice a day? So we're going to do this the old-fashioned way. So I can see you, but you probably can't see me. But how many of you think it's 30%? A. Good. 50%? Good. 70%? 90%. Wow, everyone really thinks that everyone has really low health literacy. It's actually 70%. And so 70% of people who were in the waiting rooms for these clinics in these cities actually understood that. But they took it in a different step. Now they had the pill bottles with fake pills in them, and they asked these patients who said they understood to demonstrate that. So here's your pill bottle, and here are the pills. Show me what take 2 tablets twice a day looks like. What do you think that dropped to, or stayed to? Oh, but I kind of gave you the answer already. So how many of you think A, 35%? Some hand takers there. B, 55%. Good. C, 75%. D, 95%. Great. So it's actually astounding 35%. So that is the humbling thing about medicine, is that, yes, we use teach back, but what is that? That is just recall, and that's expressing understanding and repeating your instructions. It's a whole different skill set when you're asking someone to demonstrate, please show me what take 2 tablets twice a day is. And it drops astoundingly, okay? And what they broke it down to is individuals with low health literacy, marginal, and adequate too. What astounds me about this is that even people with adequate health literacy, when you ask them to demonstrate that, it dropped. I think that is the fascinating thing, is that even people who had adequate health literacy, when you ask them to demonstrate what take 2 tablets twice a day, they couldn't do it, okay? So there are some clinically useful tools out there. Many of them aren't, though. They're meant to be used in a research environment, but this is what is recommended by AHRQ, and there's a link there for you. It's called the Realm short form, and this is the specific instructions. So starting at the top of the list, please read each word out loud to me. If you don't recognize a word, you can say pass and move on to the next word. And it's not understanding the words, but it's actually purely reading the words. And you have the list of those 7 words that are on the right-hand side of your slide there. And so you give patients 5 seconds on a word or move on. And so it's pretty useful. And the reason why I personally think that it's useful, that it breaks it down from a score of 0 to 7, depending on the number of words that they're able to say. Again, just say, not understand. Okay, and so this is where, when we were opening with the patient handout on high blood pressure, if a person could only do or read at a 4th or 6th grade level, or even at a 3rd grade level, that is really helpful to me to know that the patient handout that I'm giving you, you're not going to understand it. And so I think that this is one of the more useful tools to screening individuals for low health literacy. There's another one that is called the newest vital sign that was developed by a family practitioner, where it requires a person to interpret a nutrition label. And so the nutrition label is given to the patient that is on the left-hand part of your slide. And then you ask the patients to actually go through these questions. It'll ask you, if you eat the entire container, how many calories will you eat? And it requires you to multiply, to be able to multiply the number of calories by the number of servings per container, which is very similar to take 2 tablets twice a day. It requires the same type of skills. And so, and then you go through the rest of the questions, and then there's a scoring guide too, to show you if a person has limited health literacy or adequate health literacy. So another clinically useful tool that doesn't take a whole lot of time as well. So what can you do about low health literacy is at least ask, because many of the things that we talk about in geriatrics is a syndrome. And one of the hallmarks from my point of view of why it's a geriatric syndrome is that it doesn't get assessed. And so normalizing your assessments of, well, this is just part of the normal assessment that I do for all of my patients so that I get to know you and how I present information to you. So there's some surrogates, if you don't like using a screening tool that, for example, the two that I presented, you could ask them for other surrogates, such as, what things would you like to read, or how far did you go into school? But recognizing that even how far you went into school might not be a good surrogate for the quality of education that you actually received. And then actually asking patients to read out loud the prescription label to make sure that they can. But what I will do is ask them to read it and to deflect it back upon me and say, hey, can you read this prescription to make sure that I got that right? I think those are some easy tools as well. And there's some tactics too to easily mitigate the impact of low health literacy is to avoid technical terms. So hypertension, for example, you'll notice in the handout they refer to as high blood pressure. Be concrete in your explanations, and using an active voice is incredibly helpful too. The last two bullets I think is also important, but I'll stress that the teach-back method is only about recall. And so if you have the opportunity to, though, is to actually ask patients to demonstrate the behavior that you're trying to assess and trying to get to. And I have a video that is 4 minutes long, and I'm getting the head nod that it's okay to show, all right, that we will be on time. And so I'm going to ask to play this video. Okay.
I was sick a lot. I was sick a lot because I probably missed dosage and didn't realize it. I was in the hospital a lot. When they did give me medicine, I didn't take it right. I admit to it. I just didn't understand them, and I didn't have the nerve to ask them the right way of doing it. I just didn't have the nerve to ask them, and I didn't want anyone to know I couldn't read.
I can't read this. Well, I guess doctor gave it to me, so it's okay for me to take it.
When your children have fever, what do you usually give them?
Motrin or Tylenol. Normally Motrin, because that's what my doctor recommended.
How old is your daughter?
She is 4.
She's 4. Okay.
I would give her the 4 to 5 tablespoon and a half.
One capsule.
That's right. One capsule.
One capsule. I don't know what this is.
Twice.
Twice daily.
Okay. So how would you take this?
Well, now see, it's not only I tell you how to take it. It said take it twice daily, but it don't say what time to take it.
Do you know what hypertension means, if I asked you what that was? Because when I look at this, I think, well, maybe you have hypertension, and I've been taking care of that for a long time.
Hyper.
Like you're hyper? What does being hyper mean to you?
That's where you can't be still. You always got to be doing something.
Do you think I think you're hyper and have hypertension?
I don't know. That's what I consider it
Okay.
being,
But you know you have high blood pressure.
Mm-hmm.
Okay. But hypertension doesn't mean the same to you.
Mm-hmm.
So if I ask you if you have hypertension, you're going to just think I think you're jumping around on a chair or something like that. Something different.
Just being hyper,
Okay. All right. Well, I haven't done a very good job teaching you what hypertension is, because I think you take that medicine for your hypertension, and that's one of the things that I try to work with you on is your blood pressure. And high blood pressure and hypertension to us is the same thing.
The same thing.
Yeah.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult to for me to take these pills because if they say 1 tablet twice daily, I don't know if the child can take one in the morning, one in the evening.
like a nightmare. You walk in that office, and mostly, if you realize, the first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets. And I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign. Never read it. And then a couple weeks later, in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
Thank you for showing that video. And I think that the other thing that I'll point out is that many of us will have this on our radar when we're working with people who are of non-English speakers. But what you'll notice in that video is that all those are native English speakers, that they are more than likely were born in the United States. And so I think that's something to take home, is that you should screen people for it. Okay. Hence, I'll stop here.